YouTube link at the end with the recording.
Thank you.
Good afternoon, ladies and gentlemen who are joining us from South Africa, and good evening to those who are joining us from down under, that is in Australia. Welcome everybody who have joined us via Facebook, YouTube, Twitter, Instagram. My name is Dr. Fundi Lenyati. I'm a family physician in terms of training, but today I am the host of this Dr. Fundi Health channel. And today we have an interesting, conversation in prospect. I am reconnecting with an old mate of mine, somebody who was at medical school with me. We qualified together in 1989. You can then imagine that we've known each other for more than 30 years. Our special guest today is Professor Yuben Moodley. He is joining us from Australia, like I've already said, from the Western Australia. That's where he is based at this moment. And he is a world-class respiratory physician scientist. I had already said to him, I'm going to introduce him as a South African expert to the Down Under, that is in Australia. And just to give you a sense, of the achievements of our guest today, he is in the top 0.04% of researchers worldwide in the category of lung diseases. Now, I'm not talking 1%, 0.04%. And also, he's been rated as exceptional in the research category of the mechanisms and management of, COPD, and also interstitial pulmonary fibrosis. Those are chronic conditions that are actually, just hold on. Those are chronic conditions that actually can cause, some disabilities in some people. And those are the areas that he's specializing in, and also there's something I said in the Facebook page, that he is a man of firsts. He has had so many things that he's done where he has just been the first person doing those things. And he's going to share with us what exactly he's been doing, those firsts. But one of those is that he was the first author of a study that used human amniotic epithelial cells to treat a mouse model of fibrotic lung disease, which has been widely cited and also as one of the most cited, researches worldwide on Scopus, and it's used by researchers in 30 countries. He led the world's first study in the use of human umbilical cord mesenchymal stromal cells to treat mouse models of lung fibrosis. This has led, to another most cited worldwide, research on Scopus and cited by researchers in 38 countries. He has led the world's first study that carried out phase 1 clinical trial that delineated the immunological mechanisms of injecting human bone marrow derived from mesenchymal stromal cells in COPD patients. In his unit, they were the first to show differences in metabolites between, COPD and IPF, that is interstitial pulmonary fibrosis, and described the circulatory metabolic metabolites in progressive IPF. In COPD, they have described in seminal work the role of co-stimulatory lymphocyte receptors in the pathogenesis of COPD. Now, in simple language, he has been one of the people in the world who have been at the cutting edge of research on chronic diseases that are quite common, that can actually be disabling, looking at new innovative ways, of using cells, from the placenta and other, cells to try and come up with new treatments. But he's going to tell us about that. I don't want to mess up, all of the good work that he has done by telling you wrong things. So, Professor Yuben Moodley, welcome to the Dr. Fundi channel.
Oh, Fundile, it's wonderful to be here. Just seeing you and chatting to you brings back good, solid memories from the past. And those memories are built on a strong value system and of struggle. Because in 1989, it was a different world, a different country in South Africa.
Yes.
And we were brothers in arms, our brothers and sisters in arms.
Yes.
And we've got a very profound journey that we all undertook under those times, and it will remain with us forever, I think.
Yes, indeed, indeed. Just to tell the listeners that, the audience, that from 1984 to 1989, we were classmates. First year when we got to varsity, we were those young little boys who were put in a building that was called Beirut, which was, at the entrance of our residence, which was far away from the main campus, only because of the color of our skin. But, with those kind of challenges then, it actually didn't break us. It actually made us people who felt, despite whatever challenges thrown to us, we will actually try and be the best we could be. And that's the reason why I've invited Prof. Moodley here. I would like to just call you Yubes. That's how I've known you as Yubes.
Please, Fundile. I've always been Yubes and always will be Yubes, and that's the way it is. Yeah.
Beautiful, yes. Man. Beautiful. Just I think a few weeks ago, somebody shared a story. I'm not sure if it's you, on our common WhatsApp group, that there was a time, where some lowlives wanted to rob you guys just outside of the residence at Alan Taylor in Wentworth, and you were one of the brave souls who actually scared the guys away.
Well, actually, it was a little more a little more different than that. So what happened is, it was the end of the year, at the end of first year, and a few guys from our class were standing outside the res, waiting for a bus to the city. I was waiting for my dad, and so I was waiting with them, because he was going to come and pick me up and take me home, because first year was over. And then I think there's these three guys who came to us, and one guy had a knife, and he was pointing it at all of us, very close, coming right to us, and asking us where we were, where we came from.
Yeah.
And so then now, reflexly, you're trying to keep this guy away, and he's asking everyone. Well, I said I was from Maritzburg, so no one likes to. What can I say? No one takes anybody from Maritzburg too seriously, so I was safe. Then he asked one of our classmates, and he said he's from Sydenham.
Yeah.
So this guy said, hey, there's no, what the term, everyone knows what Charo means. So it's, there's no Charos. There's no Charos in Sydenham. And then our classmate says, well, that's because of the Group Areas Act.
Yeah.
Now, this guy decided now, should he stab us? What is this guy telling him about the Group Areas Act?
Yeah.
That kind of saved us a little, because then one of the workers came out, who we knew, for that year. He used to work in Alan Taylor. He came out with his knob kerry and told these guys to leave immediately.
Yeah.
And so he's the hero. He saved us. And we had many adventures around Alan Taylor. I don't know if you remember when they had the rocket attack on that.
On the oil refinery.
Refinery, yes. It just blew up there on a Sunday evening. Oh.
And we were human shields, because that residence was strategically put, so that if anything happens, the terrorists or whoever would think twice of doing something like that, because there are these people who have been put strategically next to it. But it didn't stop the guys from launching rockets there.
That's right. And so there were lots of explosions, and we ran out of our rooms, obviously. But I do remember asking some guys later, who were involved in the struggle, but why did they do that? And they said, oh, Yuben, if you died, you would have been, a involuntary martyr. Involuntary martyrdom.
Yeah.
And so I was just, it was a new term that I learned at that point. Yes.
Yeah. But anyway, before we talk about, your work, that you're doing, good work that you're doing in the area of research and also as a clinician, sometimes people don't get to know the person behind the titles and everything. So I just want you to just share a little bit for us, where were you born? What kind of family in terms of size? Were you the firstborn, secondborn, lastborn? And what kind of values were instilled in you as you were actually growing up that are still your compass today in Australia?
Yes, thanks, Fundile. So I was born in Pietermaritzburg, or Undenglovo, the place of the elephants.
Yeah.
I've got a sister who's still in Pietermaritzburg. She's a nurse.
Yes.
So I was the firstborn. She was after me, Tasmi.
Yeah.
In fact, she's married to a surgeon. He's the head of surgery at Gray's Hospital and Northern Natal, KZN. Yeah. And so that's my sibling, my sister. But we also grew up, as you well know, with lots of cousins, and they were uncles and aunts. And so, as they say, it takes a village to raise a child. Yeah. And so I saw all of them as brothers and sisters, and multiple parents, because your uncles, aunts, they all input. At that point, when you're growing up, there was lots of input of various people. You took this from people, that from people. Yeah. And so, and then what were the big issues? I suppose.
So just there, Yuben, you've just mentioned that, the concept of it takes a village was actually practical, in your case. And every adult had a right to punish you, if they found you transgressing, doing something wrong, and even take you to your parents, who will also add up, to try and get you to go the straight and narrow.
That's right. I think, and that's been, the big thing. I think it's impossible to grow up in that society without apartheid and racism affecting you.
Yes.
And I think that is something which we all experienced, and it stays with you. And so, for example, I think my first kind of experience with what I would regard as racism is when my aunt used to take me for walks along the Durban beachfront. Yeah. And they used to have these rides, and they had these go-karts.
Yes.
And so I used to ask her to, can I go for a ride, or can I go on the go-kart? And she used to make some excuses. And then it's only when I got home, and I was still a kid. I'm not sure if I was still I don't think I was in school. And the first time I heard, she said, oh, how am I going to tell him he's not allowed to drive those go-karts because of color of his skin.
Yes.
Now, go-karts at some level was obviously a superfluous thing, a superficial thing. But I think our education system, the differential resources put into the different races, and all of those things is a deep injustice which affected us all. But I'm glad to say my family and extended family, I think, were on the right side of history, because I had uncles, aunts who were human rights lawyers who took up the struggle, and my parents and grandparents, I would say collectively we recognize the injustice and tried our best to address it in whatever means we could. And so I think injustice and things that are discriminatory, racism, caste systems, gender inequalities, all of those things, I think we have now a zero tolerance for. And I think I was happy to be raised in a family which espoused those values. So
beautiful.
it wasn't anything that was, really different. And I do believe, medicine and activism and social justice is very important, because as you know, and as I know, tuberculosis, for example, can spread through informal settlement. And underlying problem is not that these people, are exposed. It's the underlying problem is the settlement itself and the overcrowding. And then you think about, then you have to analyze, how has that overcrowding occurred? Where is the dynamics around that? And then it starts to become political after that. The whole range of socio-economic justice. And I think that's the underlying theme for our lives. I think trying to, there's the science and there's molecules, but socio-economic justice, I think, is probably one of the biggest things that we are all striving for.
Yes. So so any highlights, in your high school years before you got to varsity, anything that you could say, what, this was my highlight, or at what point did you decide that actually I want to do medicine?
So I wanted to be an engineer, mainly because there was, this creative scientific component to it. And I sat with a engineer from Lever Brothers in Durban. Just sat with him in his office. He was a chemical engineer. And he showed me a graph of things. And I got a bit perturbed, because Lever Brothers, whatever profits they were making, seemed to be going out to England or the UK. And it's almost, I felt like, you're working for some person's profits, outside South Africa in some respects. And then one of my uncles, who was a GP, he spoke to me and said, medicine is a great career. And my dad told me, medicine is a great career. And he wasn't a doctor, but certainly in our society, doctors were highly thought of. And so there was a combination of different things. And when I got to med school, it was as if, I thought, I'd made the right decision. I wouldn't do anything else. And even now, if I had the opportunity, I probably wouldn't do anything else, because I thought that it's such a wide field. And, as you are educating people about things in your own way. And, you can do law and medicine, or economics and medicine. There's basic science and medicine. So it's a wide range of things you could do.
Yes.
And that's and I think as you go forward, you appreciate the huge responsibilities on you
Yes.
as a healer,
Yes.
the trust that people have, especially in lower socioeconomic circumstances where the trust in you is complete and the responsibility you have to your fellow human beings is immense. And so it's almost like it's like nothing I know where you can alleviate suffering and you can do it in a way that, well, the alleviation of suffering is a privilege. Yeah.
Yes.
So highlights in high school, well, just making it to med school or making it to med school. I wasn't very good at Afrikaans, even though I had good teachers. I had this I got this uncle who used to tell me he was, an ANC cadre in certain ways. He was a lawyer, and he said, "Oh, don't worry about Afrikaans. It's going to be a dead language soon." And I never really, concentrated on Afrikaans, and fortunately, I could rely on the other subjects to get me across the line.
Yeah.
Yes. So in high school, I suppose it was more. I think it was perhaps your relationship with your teachers.
Yes.
Because they were your role models in many ways.
Yes.
And so I think if I think about it, the teachers that I had, for no extra cost, they would start school at 7 o'clock instead of 8, and they'll finish at 5 o'clock teaching us and trying to push us forward.
Yes. And like you say, they did that because of the love of imparting knowledge and trying to ensure that you guys, all of us, you get ahead without necessarily saying, I need this extra for overtime or something like that. Yeah.
My high school, Woodlands, was in Northdale, which was a lower socioeconomic area in many ways. And so the other highlight you had in our high school, unfortunately, we were all of one race, but our socioeconomic distribution was complete. You had the very wealthy and the very poor, and we all were in school together. And we all tried to lift each other in many ways. And I enjoyed sport quite a lot. So I'm going to tell you a story in terms of sport in high school. So we had a lawyer in Pietermaritzburg that he's late now, called Mr. Kader Hassim. And he was Robben Island. He was released from Robben Island while I was still in school, and his office was close to the squash courts where I was trying this game out, and then he was coincidentally there, and he knew my dad and uncle very well, and so I used to play squash with him, and he used to talk politics, but in hindsight, it was quite therapeutic for him after his release to, play squash with me. And so the other highlight was that my family was one of the oldest Indian families, at least in Pietermaritzburg, and so everyone knew us, and it was a positive experience. So that was high school.
Beautiful. All right, so you got to med school, and then again you had been prepared nicely by coming from a diverse community, from rich to poor and whatever, at the school that you went to, but it was still one race. Now you get to varsity and you are put with all the other races except a white race. That is, Black Africans and the Coloureds and the Indians were all together at Alan Taylor residence because group areas Act did not allow us to be at the main campus, So how was that experience, of now interacting with other groups, because to some of us, like for me, coming from Umtata in the Eastern Cape, it was a bit of a challenge at the beginning because I was used to people who spoke my language, which was Xhosa. English, I was not so much into it. All of a sudden, you get to varsity, your roommate speaks a different language, and he comes from a different, sometimes race, and you have to now master English on one side, and the other side understand certain cultural nuances.
So that was probably one of the happiest times, really, because with those challenges, it threw up the happy times, because it wasn't as hard a struggle. On paper, it was a struggle, but we were just fellow human beings, really.
Yeah.
And we came from different backgrounds and different language groups and different experiences, but our commonality was greater than those differences.
Yes.
So often, I tell people that when I first came to Alan Taylor residence, I was really looking forward to this diversification. I was tired, you read, you listen to music, you know that the world outside is diverse, that our natural state is diversity. Our natural strength and state is diversity. So, I then said, oh, it's going to be really exciting. I came there with my dad. And then I was asked one of the saddest questions by Mrs. Konati.
Miss Konate, yes.
So
she was the matron, right? I think she was the matron or something like that of the residence.
She said, oh, welcome, this, that, and the other. She asked me, would you have a problem sharing a room with the African student? And I was taken aback. I said, give me an African student, because, I thought that was a sad question, because it reflected the state of many people's minds.
Yes.
That, people, because of our historical backgrounds, that we didn't want to actually join forces and mix. And so anyway, as you well know, we were in first year Beirut. We were what can I say? We were a group unto ourselves. And then for me, I felt that laughter and getting to see each other as not only human, but as friends. And with friends, joke and all of those things. And so I have to say, this many people may not believe it, but you were witness to it. So I remember once, first few weeks in first year, our lecturer in social anthropology, she showed a film about people walking across the fire, these Hindus in Sri Lanka. And all the guys were like, oh, this is not good, we believe in our ancestors. And so then Muhammad Jogiat and myself, we said, hey, you know what, we can scare these guys. Let's try and scare them by pretending to be ghosts. So one night, we said we'll do it on a weekday, because then no one will suspect, everyone's awake in the weekend. So one guy will control the lights, the other guy will put a white sheet, cut his, cut eyes there, and then we'll see. So, and we went into 2 or 3 rooms, frightening people, and the guys were scared. And I remember, I'm not sure, Luba Balu, he was with us in first year.
Yes, Luba, yes.
He threw a bottle at us because he didn't know who we were, and he started to, he threw a bottle, and that hit the wall. The guards from outside ran in. And I thought, oh, we're going to be expelled. And then Luba, because we had taken the sheets off. And Luba Balu told the guards, what are you guards doing? These spirits, they are tormenting us. I don't know which informer told everyone, because when we walked into the lecture theater the next day, everyone says, there's the host, me and jokes, or jokes and I. But that's not to break the ice in many ways. And
Yeah. Yeah.
so much from, and being with African students especially shaped a lot of my worldview.
Yeah.
Music, sport I played,
Yeah.
your attitudes. And, my heroes would be Madiba, Martin King, sporting heroes, and so I think in the end, though, our humanity is stronger than our differences.
Beautiful. Exactly. Exactly. All right. So we were together for 6 years, and then at the end, 1989, we qualified, as medics. And Prof. Mayosi, the toast of our class, and we were lifting him up and all of that. And from that class, we've kept those bonds even today. In our WhatsApp group, we are a tight group of super achievers, in various aspects of life. So, but now what I want to know, when you then got that degree on the 23rd of November 1989, what went through your mind?
Well, final year was tough for me because I had a few health issues. I had AVMs and one ruptured, and I had some hemoptysis, which then they took me to Wentworth, they embolized it, and I was like one of the first successes. Then I used to carry these kids around, in King Edward while I was doing pediatrics. One had TB, and I caught TB in my final year. So then instead of doing my internship it was really something which threw me a little final year. And so I said I need to go back home to Maritzburg to do my internship there. So when I got there, I did my internship between Gray's and Northdale Hospital. It was quite different because everyone knew my parents. And I remember one senior doctor telling me, hey, my boy, you make a mistake here, your father will know about it before you get home. So, so then, and then what happened is I felt, final year couldn't really achieve my potential as such. And so I said, look, I need to, I felt being a real doctor now, that I was in my element now, And so then it was either surgery or medicine, but medicine is more intellectual and more, all respects to my surgical buddies, but it had a level of contemplation and science to it. Which,
and remember, we were products of Professor Y.K. Sidat, and almost all of us, we looked up to him. This was the guy who doesn't bring a book, to the lecture room, and he just, lectures, and then he stops at a particular point, and the following day he'll just say, where did I end? And then he had everything in his mind. So for many of us, he was like the hero.
Yeah. So anyway, I went and after 1 year in Pietermaritzburg, I joined the teaching program in medicine. And I don't know, I worked much harder. I don't know how possible this, much harder as a registrar studying. And I taught by heart the Harrison's Volume 1, Volume 2. And I used to then have discussions with him. I think my big break came when the Professor Sidat didn't pick up a rare condition called TTP in one of the nurses who came in with confusion, renal failure, and anemia. So on the round, he was telling people, well, this is Evans syndrome or something. And I told him, no, Prof, you know what, I think this is TTP. So then everyone's looking now because no one challenged him in the past, and we made trouble challenging him. Anyway, it turned out to be TTP, and he used to call me Moskowitz because of the guy who invented or discovered this syndrome.
Yes.
Then I think for me, the biggest game changer was I was his registrar for 6 months.
Yeah.
And we used to have our battles, on the ward round in terms of, challenging each other, and he enjoyed it. And we became close in some respects. And then I got my exam. And then I thought, well, let me just go back to Pietermaritzburg to find my feet in some ways. But then
as a specialist physician at that point.
Yeah. And then when I got there, I saw within a few months, I felt quite bored by things. Well, not bored. I mean, I thought I needed something extra. So I went back and saw Prof. Sidat, and he was going to send me to Australia, ironically, for further training in ICU. But then there was the AstraZeneca fellowship that came up and in respiratory medicine. And I applied for that and got it. And so that allowed me to train in respiratory medicine.
Yeah.
And then I found that as I was going on, I did my MD in nitric oxide and its measure of lung inflammation, which was a very novel study. People were studying non-invasive markers of lung inflammation, and we would do nitric. And then I realized that I've got a kind of a strength for molecular stuff. So, these molecules, I felt it easy to understand. And I felt, well, that's my strength, molecular cellular medicine. So I did and then I presented it in the American Thoracic Society, my findings. And I was so excited by the response that I left my bag in the lecture theater. And then I went and I was talking to the editor of the European Respiratory Journal. And then I went back and there was an Australian called Professor Philip Thompson. Yes. And he chatted to me and he said, you know what, I do a similar kind of work. And then I felt I needed to lift to another level, which was not available in Durban at the time. And I wanted to do my PhD in molecular medicine as such. And so I phoned him and he said, come over. So
he was in Australia.
He was in Australia, yeah. And so I did my PhD. So my PhD was sitting in the lab and just working with cells and molecules, really. But I used to do clinical work every Friday night and the weekend. I used to do calls. But from being a consultant in South Africa, I was now a registrar here.
Again.
So then I had to do it again. In terms of being a consultant here. But my wife is a Natal grad, and I was a consultant. She was a med student. There's a lot of those we can, in hindsight, discuss the merits or the ethics of all of that. But anyway, we met. Oh yes, so this is, I think, an important thing. When I became a specialist and a consultant, I had to decide, and this is what everyone else will go through. What kind of consultant you're going to be in terms of your persona. So as you know, we had strict consultants who gave us lots of hard times,
Especially the ones who had recently qualified.
Yes, they had something to prove. And so I had to say, now, what am I going to be? And then I'm thinking, well, I can't be strict even if I tried, it's just...
It's not in your nature.
So I had to say, I said, look, I'm going to be one who will work very hard, set a good example, study even after that. But in terms of my juniors, I'll treat them more like equals, human beings. And so what I used to do, Kenny and Yamande we used to also help. We used to arrange soccer matches every Thursday down in Berea Road. It was indoor soccer.
Yeah.
So we used to play with the registrars, and we used to play medical students from every class, so fifth years, fourth. And Brian Verzi, who's a cardiologist in Durban, he used to play, with us and stuff. And so my wife came to watch us play her class.
Yeah.
I think she was really impressed with my Jomo Sono moves.
At that time, she was not yet your girlfriend or anything.
No. Just came to watch us. Yeah. So I think thereafter, I have to say, you mentioned it earlier, but when I went to the US, in that first meeting of mine, I felt, well, look, you've got your school is school, medical school is medical school, but this is a long journey.
Yes.
And those are just, how can I say, if you're running 400 meters, that's 100 meters, 200 meters. You got 200 to. And so when I met some of the biggest names in respiratory medicine, chatted to them, chatted about my work and things like that, I got a lot of support from those big names. And then I decided, look, you could be, there's not, even though we came from humble beginnings, there's opportunity. Talent is, and I'm not talking about myself, but talent is all pervasive. Opportunity is the limitation. I feel that with opportunity, or if you give everyone the adequate opportunities, who knows where they will go. And I felt that you switch it on and you say, right, you can be world class. You can, if you work hard, you go for it, nothing is going to stop you. World class. And I think that's what I hope to every young person, is that you've got to actually be able to surpass. You've got to be able to allow the next generation to surpass you. They have to stand on your shoulders. So you've got it to this level, you pick it up, and I think that's, that's very important. And
I think that's very important, Yubes, because at times, in the past month or so, I've arranged webinars of colleagues around the issue of academic bullying in medicine, and one of the things that came out from some people was that some of the consultants, when they see this young, bright, up and coming registrar who is most likely going to do better than them, they sometimes get a bit threatened and want to suppress. So for you, what you've just said now, that it's important to actually see that there shouldn't be any issue about the young ones surpassing you, because the next generation should always be, if possible, better than the previous generation.
That's right. And I think that's critical, because that's how society progresses. And, and that's what I always aim to do. The juniors are trained to be better, and in our alma mater should also aim to be the best they can, world class, because they have the talent. It's up to us to provide the opportunities and the insights to clear the path to a much stronger future.
Yes. So obviously now you were working in the lab, doing your molecular stuff. You got your PhD, right?
Yes.
Right. So now the question is, most people think, okay, once you get to PhD level, like what's more now? But there's postdoc this and postdoc that, so when you got your PhD now, then what was next for you?
Yeah, so what happened is I did my PhD, and that has put me into a lot of training regarding molecular and cellular biology. And then my mentor here, Prof. Philip Thompson, I used to go to him and say, "Oh, look at that guy, he's got like a few hundred papers and stuff." And he says, "Oh, you know what is the impact? What is, no matter what the papers, what is the impact?" And then when I was in the US and, in certain centers in the UK, valued clinicians doing molecular science.
Yeah.
That was, the I wouldn't say the ultimate, but that was for them highly regarded. And I trained myself, so I'm going to actually do molecular science and medicine, because we were superb clinicians, and now I can marry the both. So at that point, post PhD, to be honest, we were planning to return to South Africa. But then what happened is my wife, maybe it's chance, maybe we couldn't really get anyone to work out. She wanted to work, and we couldn't get communication going between South Africa and Australia regarding her job.
Yeah.
So then a training post in psychiatry, which is what she wanted to do, came up in Australia. So we said, "Oh, well, train here and then we can go back and see how we go." And then, as you well know in life, 2 kids came along.
Yeah.
Then offered me an academic post, and then we said, "Well, let the kids grow and we'll see how it goes." And one thing led to another.
Yeah.
Yeah, and so it wasn't a move out of South Africa for the sake of moving. It was,
it was not like the other South Africans who peck for path. Yours, it happened by chance, opportunity rather than a considered one.
Yeah, and so as the opportunities here, or as the kids grew, we were starting to feel more anchored here. And then, communication now with WhatsApp, all of these things became a bit easier. And then I was always wanted to give back to our alma mater, to the people, it was always going to be that case.
Yeah.
But for some reason or the other, in Derbs, it was difficult to create the collaborations, because I think it was just run by a different generation at that point.
Yeah.
And then our classmate and venerated dean, Nkosa, so when she became dean, I thought, "Oh, there you go." So we made contact, and we were starting to create opportunities for both places. And also, well, then COVID got in the way, but I'm sure we'll be able to do so.
Yeah.
And, you wonder how things would have been different, but I think that given the way the world is globalized, the communication, I'm talking to you.
Yeah.
I think distance is not such a big,
yeah. All right, let's get to the work that you are doing, the cutting edge work that you guys are doing. Firstly, in almost everything that I'm reading about you, obviously being a respiratory specialist, you've covered a broad range of diseases, asthmas and other lung diseases, lung cancers and whatever. But there are 2 that are associated with you. Chronic obstructive pulmonary disease and also interstitial pulmonary fibrosis. Why these 2 diseases as an area of interest for you?
Okay, so the pulmonary fibrosis is the fundamental process of nature.
Yeah.
So what happens is you get a scar, or well, you get cut, it either heals or it forms a scar. So every organ system forms a scar. If we can reverse the scar, that would be the holy grail, where we replace scars with normal tissue.
Yeah.
Now, nature's way is to form a scar. And so how that scar forms, why it forms, can we reverse it using molecular means, therapies, is me the ultimate question in medicine.
Yes.
Because when scars form, let's say in the lung, for example, they destroy normal tissue. And that's where people start to suffer because you get a lack of oxygen, you get a lack of blood flow, and so the normal tissue is destroyed and the scars formed. And I think under those circumstances, it's something which is the, as I'd say, a holy grail question.
Yeah.
Can we reverse scar formation?
Yeah.
Then in terms of COPD, it's a very similar situation, except that COPD is the top 5 most prominent diseases in the world.
Maybe just for the benefit of those who have not gone to medicine, just in 1 or 2 sentences, what COPD is.
Okay, so usually it's caused by smoking, but not always. And over a prolonged period of smoking, you get damage to your lung. And some of the gas, where the gas exchange, blood flow occurs, is destroyed. And then the airways become inflamed, and they always produce mucus and inflammation and infection. And so you've got a very diseased lung as a result. Now, it could be mild, moderate, and severe. And there, the holy grail is, can we reverse some of those changes? Can we reduce some of the inflammation? Because in many patients, even though they stop smoking, some of this inflammation is still continuing.
Yeah. So basically then, whether we're talking this pulmonary fibrosis, that is the hardening, of the lungs from fibrosis, or the chronic obstructive airways disease, largely caused by, smoking, but can be caused by others. Basically, it's the same thing that you are talking about, how to reverse the scarring that takes place.
Yeah, so there's 2 processes here. One is your first aim is to reduce or stop the decline in the disease.
Yeah.
And second, which I'm not sure when we'll get to, is to try and reverse it.
Yeah.
You can stop the decline and stop the progression of the disease, then that's going to actually make a big difference to the quality of life for people. Now, the other thing about fibrosis is many things cause fibrosis. TB, fibrosis. You get inflammation, fibrosis. COVID, inflammation, fibrosis.
Yeah.
Occasional lung diseases. They all cause fibrosis. So understanding that mechanism is going to be the biggest, the biggest issue.
Yes. All right. So just to move a little bit faster then, so you decided these are the areas that your team, your lab, is going to be focusing on. And you guys have now come up then with new innovative type of interventions, or what they call cellular therapies. Can just tell us a little bit then about what you guys are doing or what you've already achieved, because there's a lot of cutting edge stuff that you've already achieved using these new modalities of treatment.
So I felt that the way in which you can improve lung diseases is by putting healthy cells into a diseased organ. Now it's very complex because where the cells go, what kind of cells. So cell therapies was a big thing for us, and I did some work in cell therapies where we tried to actually find healthy cells and ways in putting those healthy cells into lung in order to reduce fibrosis. So we looked at, one of the studies looked at the human placenta, because the human placenta does not reject the baby. So they are immune privileged cells. So you can inject them into anybody. And so we used those cells to treat a mouse model of lung fibrosis and found that these cells release things that improve repair. So we went to a situation where we then tried to use these cells to then treat human beings.
Yeah.
And babies in order to actually work out whether it reduces, whether it's safe or not.
Yeah.
And so in our studies, we found that it's not just the cells, but it's the products of these cells that actually induce repair. So what we are harnessing now is not only the cells, but the products they release. So one of our recent studies is we injected the cells into humans to see what immunological changes occur and how it affects the body, and harness those mechanisms to work out if these cells can then be used therapeutically, the products could be used therapeutically. So now we are nebulized because we don't have to inject it. It's much more cheaper. It's direct access to the lung. So we're checking the safety and then probably look at efficacy studies. But
and that's the work that you guys have just started now in May, about a month or two ago.
Yes, so we'll complete the safety study, and it's generally quite safe. But the other thing that our two major things that we're doing now is we are changing stem cells into lung tissue by using embryonic pathways. We got cells from a collaboration in Boston. And so in our lab, we are taking the stem cells. So they're taken from skin or from blood. They are transfected with these genes, which make them, which give them the ability to change into various things.
Yeah.
And then through each step of the embryonic pathway, we are trying to treat them to change them into lung cells. So that's the first thing. The other major thing we are doing now is we know we've got the gene, but the epigenome is the control of those genes.
Yeah.
And, we are trying to work out what epigenetic changes occur during these chronic lung diseases. And so by doing so, perhaps if we can control the epigenetic changes, we can reverse that process. So those are the two major things we are up to there, and we'll see how it goes.
Yes, beautiful, beautiful, beautiful. And, I mean, this work, like I said in your introduction, in each of these firsts that you guys have come up with, researchers across many parts of the world are actually citing your work, as a groundbreaking work in this area. All right. Now, I think we will wait and see how things progress. We wish you guys all the best, as a South African that is out there and making things happen. It makes us proud, sitting here at home. But now let's come back then to the issue of COVID-19 pandemic, because we are now in the middle of COVID-19 pandemic, and being a largely respiratory disease, obviously any other system can be affected, but it's largely respiratory disease. I just want you to just talk to us, what are the challenges? Why is this virus, this SARS-CoV-2, sometimes other people, it doesn't cause much problem, but then other people, in no time there's a COVID pneumonia, and then if they are lucky enough to survive, others, they've got scars for life, post-COVID syndrome. Just talk to us about COVID-19 respiratory issues.
So with COVID-19, I'll summarize.
Yeah.
The main issue is that our immune systems has not seen this virus before. We've seen many other viruses, hepatitis, influenza, and to some extent we have an immunity to it. SARS-CoV-2 we haven't seen before.
Mm.
So as a result, our immune systems are in a panic when the virus enters our system.
Mm.
So the reason why some people get or survive or live through it or have mild disease or even asymptomatic versus serious disease is based on one fundamental issue. For some reason or the other, the immune system in those patients who are asymptomatic or mild can clear the virus. Somehow or the other, they have the antibodies to improvise, and then they clear the virus. For those patients, diabetics, elderly, high BMIs, for some, especially diabetics, elderly, their immune systems are already immunocompromised.
Yes.
When they see the virus, they can't clear that virus. The virus is sitting there. So then what happens is the body now says, well, I've got to fight it again and again. So you've got these waves of inflammatory cells that the body is trying to use to fight the virus. But what happens is these inflammatory cells flood the lung or other organ systems. You've got this major inflammation, and that's where the problem lies. That's why those people who can't clear the virus as well as, say, their peers get the severe disease.
And so it is those waves that then cause the damage, that then makes other people who have severe disease. So that COVID pneumonia is coming from that, extensive inflammation.
Yes, exactly. It is the abnormal immune response that causes the damage to COVID, as opposed to the virus itself. It's mostly the dysfunctional immune response. Yeah.
And so obviously this thing has only been with us just about 18 months. I mean, treatment interventions, are still not very clear. We don't have a clear cure, no clear drug that is actually, fighting the germ itself, whilst I think the inflammation maybe can be managed. So what are you guys coming up with? I'm asking you as, a guru in that space.
Yeah, so I think there's going to be various strategies, but the strategies could be categorized into having medications that will fight the virus directly.
Yes.
And you'll have medications that will suppress the immune system, thus increasing the healing. So at the moment, there are drugs, not my drugs, obviously, but as there's drugs from our profession, let's say, that have shown, so let's go mild, moderate, and severe. So mild disease, you don't need oxygen. Moderate disease, you need oxygen, no ventilation. Severe, ventilation, right? So in those mild diseases where they don't need oxygen, there are these drugs that you could use. Now, a lot depends on, I suppose, the resources of the country, availability, but I'm just talking about in the ideal world. There are drugs that use monoclonal antibodies that bind to the virus, inhibiting their function and damage. And so you can use
that. Reginon is one of those. Is Reginon or something?
There's the baricitinib, remdesivir, those types, and then banlivimab, and there's carasivimab. There's big names, but they, at the initial step, are used to actually prevent severe disease. Then when you've got the oxygen, and if you're on oxygen, then, remdesivir, which reduces the viral replication, plus dexamethasone or steroids that reduces the inflammation, come into play. And then it starts to become severe. You add on the anti-IL-6, which is another anti-inflammatory drug.
Interleukin.
Tocilizumab, which reduces IL-6, and that could be used in patients who are on the ventilator. Now, there's lots of clinical trials coming up, and our main drug, or not drug, but our main intervention is vaccination.
Yeah.
These are, the prevention versus the cure.
Yeah.
If it wasn't for vaccination, we as a human race would be under severe threat. It's the vaccinations that give us the insight into our immune system, the insight into, hey, okay, now there's this virus, so this is the protein. How shall I fight it? When you then confronted with the real virus, you are able to actually then mount a response that prevents severe disease. So the world and every country has, I feel that there's too much of complacency, too much of nationalism. We have to vaccinate the world as fast as we can, as most effectively, because if you leave one area of the world out and you just vaccinate your own population, then that virus is the height of nature, and it'll be multiplying and mutating. And you'll find a mutation in some part of the world that will get to your country anyway.
Yeah.
So that's what we're dealing with at the moment.
Yes. Now, I will not have done justice to the questions if I don't ask you about two treatments that are dividing the medical community at this moment. And so I want your opinion on it. One, ivermectin. In South Africa, there are those colleagues who swear by ivermectin, despite the lack of, scientific evidence. Even with the recent study that was done in Argentina, which was published, I think, on the 2nd of July. So, but it's also there in the black market, and everyone thinks they should have it. So, I just want to hear your view around ivermectin, and also, chloroquine. Also, because in the early part of the of this pandemic, there were those, and funny enough, it's the same people who are pushing chloroquine, who are pushing ivermectin. And I know that chloroquine, in the Solidarity trial that the WHO did, it actually stopped that study because of some of the adverse effects. So I just want to hear from Prof. Yuben Moodley, is there a role for ivermectin in the treatment of COVID-19, prevention and treatment of COVID-19?
So from my reading and in my opinion, the answer is no. There's no evidence there have been trials, and some of these trials that may show some positivity have not been well done. And so after all is said and done, I would not recommend ivermectin or chloroquine or hydroxychloroquine.
Yes. You see now, one of the challenges, Yubes, is the fact that this information is available not only in the scientific community, articles in scientific journals, but it's also available in the social media space, and stuff. And so not everybody has the depth to understand what is a well-constructed study. So just what is a well-constructed study? That thing of the randomized, double-blind, placebo-controlled, and all of those things, just for the benefit of those people who might be listening.
Sure. So I think if you're going to test a treatment, you're going to test it in the same disease cohort with similar severity. So let's say if you choose patients with COVID who are on oxygen, not on a ventilator, and not those that require oxygen. So you've got your clear cohort. then you blind it. So no one knows what anyone's given. So and then you randomize it. So you don't know who's getting what. And so when they talk about double blind, you are blinded, you don't know who's getting it, and you randomize because anyone in two groups get it, right? The treatment group, you got a placebo. They're the same color, no one knows who's getting it, no one knows how they don't know who's getting it. And at the end of it, you've got a study where you know what numbers are placebo and which numbers are
the actual drug you're testing.
and it's all labeled and sealed. So then what happens is you then work out what are you trying to achieve. So if your first aim is to make someone on oxygen get discharged from hospital, or do you get them better and they have a normal life after that? So your outcomes are important. So then when you do the study, you collect all the data. Then you break the seal and you work out what the drug did, let's say in terms of reducing oxygen requirements and going to discharge versus what the placebo did. And you compare it, and then if you come out with the drug doing much better, then you can say, well, this was a well-constructed study and this is the outcome. Now, many of the studies when COVID started is they were just giving people willy-nilly medications, and then they were drawing conclusions from that. And I think that's where some of the misunderstandings took place. Now, it's not just my opinion. All the guidelines across the world would suggest that ivermectin and hydroxychloroquine is not effective. Now, the problem, though, is what drives all of this. Like I've mentioned some, drugs in the beginning of our discussion.
Yes, remdesivir and the others.
Yeah, and some of it may not be available to the populace because of cost, and the resources may be limited, and that's a large part of this world. And so sometimes something that costs less, and maybe social media says maybe give them a chance, becomes more popular because that's what people have access to. And I think that's the other concern, because of a lack of equality to the best practice, people are then turning to things that may not be scientifically proven, but maybe less costly and more available.
Yeah. Okay, no, that's good. But I mean, I think when one goes into, whether it is BMJ or Lancet or all of these top journals, there's so much research that's coming out, about different aspects of this. I think there's been an explosion of research in the last 18 months. And, as a medical person or a scientist, one has to be up to date to see, what's happening, who's doing what, where, But anyway, let's now leave the professional side of you, because we are about to wrap up. We've only got 15 minutes to go, and it's in the evening on your side there. It's 11:15, so that's quite late for you.
Okay.
Yes, all right. But now what I want to know, you are doing all this great work as a professional, as a physician scientist. But I know you as somebody with a full life beyond just the professional work. You've got interest in sport, you've got interest in music, and you also love spending time with your family. Let's look at the sports side of things. A few weeks ago, I saw you in a bodybuilding competition or something. What is that?
Well, I think if I had to wish one thing for my fellow human beings, it's good health. And you always learn that good health you got to work at it.
Yeah.
And to be able to, and I find that, especially in our generation, sometimes after 30 or so, you kind of give up and, you sit around and stuff. But I feel that your quality of life is greatly enhanced by exercise, and you've got to be
Yes.
pushing all the time.
Mm.
And so I do weight training and I take part in these competitions, not just weightlifting, but
Yes.
high intensity work. And by chance, I found that, I may not win it with the 20-year-olds, but competing with them is enjoyable.
Yes.
And so, yeah, though, I coach soccer here.
Mm.
My son was in a soccer team and played a bit of soccer, and I played a lot of squash while I was in Australia. So,
Yeah.
I think though that always, well, I did a CT angiogram before I went into high intensity work just to be
Yes.
sure.
Just to
Because
make sure that you don't get an, a cardiovascular event.
it's embarrassing to be in a high intensity competition and, uh, hurt yourself, especially your heart. So, I think, yeah, so the sport is, I think, very important. And as you may well know, in Australia, sport is a,
The religion.
yes, that's right. So, yeah, if you don't play sport, you are, you're one of the unfortunate ones.
Yes.
That's like,
Yes. 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 So you.
that
So
way.
besides that, are you back in squash, or it's just the work you are doing on the bodybuilding side and stuff?
So it's just the high intensity work, because what happened was, as you know, I used to wear glasses, and
Yeah.
then I had surgery to correct things. But I played in a competition and I got hit in the face,
Yeah.
but I had glasses to protect me.
Yeah.
And then I had to go and check the ophthalmologist, and my wife was with me. And he said, look, you've got to give it up because you're at risk of retinal
Detachment.
because of my myopia. So I said, okay. And then I couldn't come home and tell my wife, oh, everything is fine and I can play squash. She was there,
Yeah.
right there. No more. So anyway, but there's always enjoy. I would advise everyone to do what they enjoy. So if you like to run, like some of our classmates, or
Yes.
basketball or whatever, just do it.
Yeah.
But don't let exercise be something that you put aside.
Yeah.
Default. Start your day or end your day with exercise and make sure you do it, rather than, well, I'm feeling tired, I'm not going to exercise today, or
Yeah.
it's cold outside this morning, I won't exercise.
Yeah.
I think that's part of your persona.
Yeah. Okay. So the music side of you, the playing of instruments, in one of the things where they were profiling you, and they asked you what was your best purchase, you mentioned that it was the Selma alto saxophone.
Yes.
And as the classmates, we've seen you play a few times, in our WhatsApp group. Tell us about your love for music and the playing the saxophone.
Well,
Is it is
I
it is it very far from you, where you are sitting now? That saxophone,
it's
is
in
it very
another.
far from you? I
Uh,
thought as we finish, you could just play us one song as we go out.
okay. Let me. What shall I do? Shall I just?
Just switch off your camera for a second. We'll wait for you, and then you can bring your saxophone.
Give me 1 second.
Sure. All right. We are actually going towards wrapping up our conversation. It was meant not to be a hard technical type of interview, because we have got a wide audience of people, those who've done medicine and those who have not done medicine. And so I needed to just, help to profile the kind of work that he's doing, cutting edge work that he's doing, and the fact that even though he's on the other side of the Indian Ocean in Perth, but he still has his heart here in South Africa, and he's actually working with our alma mater, University of Natal or UKZN, with Professor Ngozadlova to see how there could be some form of exchange programs in terms of research and other areas of interest. So I can see he is back. Yubes?
Helps you work more efficiently, which makes accomplishing your work goals easier.
Give me 1 second.
Get full sense.
Okay, so I'll play a few lines from a classic called The Way We Were it was originally done by Barbara Streisand.
Yeah.
But what happens is I heard Beyonce sing the song.
Yeah.
And I just said, oh, that would sound good on a saxophone.
Yeah.
So
take it away.
Okay, so I'll play 10 seconds.
That's fine.
Okay, there'll be some background music.
Okay.
There you go.
Wow. Wow.
The whole thing, I'll put it on WhatsApp for you.
Please, that's nice. That's very, very nice, Yubes. One wishes we had more time, but anyway, we're still gonna have our online reunion. I'm sure you will play some of these songs there.
Yes. So the reason I chose the saxophone is because it was the closest, one of the instruments that, identifies it's noted with black music, African American jazz. It's the coolest instrument I was given to understand. So that was yes.
And the Selma brand, what about it? The Selma brand, that makes it. You say it has given you lots of enjoyment over the years. It's the best purchase of everything that you've ever bought.
Yeah, well, it's the longest I've got it. So I was doing my internship in Northdale. One of my friends studied music in Germany.
Yeah.
And he came, and I had this cheap line Jupiter saxophone. And I said, oh, my major aim is to buy a Selma saxophone because that's the top range. So then what happened is he said he can get it for me half price because I couldn't afford it because he had an international music passport.
Yeah.
Then I said, okay, fine. But I was in a big dilemma because I went to the clinic and there was all these poor people that I'm treating. And I'm thinking, I want a saxophone, which is so expensive. How could I, justify this expense? Anyway, someone coincidentally called me and I explained this dilemma. They said, look, it'll enhance your life. It's not such a big issue. Buy the saxophone. So I bought the saxophone at half price. It came to the post office in Maritzburg.
Yeah.
Anyway, when I got there, it's the old system. They open they opened this and they saw this shiny instrument.
Yeah.
So they charged me tax on it. So I had to leave it there, save my money until I could pay for it to be released.
Yeah. You know, it was as an intern those days. I mean, we used to earn somewhere between 1,000 and 2,000 rands a month. You know.
That's right. Yeah, that's right.
Right. So as we wrap up, Yubes, you know, what would you say has been your secret, you know, to your success at a professional level, but also broadly, you know, as a person?
Okay, I think as a person, I strive to make people laugh, I think.
Yes, you did a lot of that whilst we were at med school.
Well, and so I'm not scared to even look silly, because when someone's smiling or laughing, life is tough for everyone.
Yeah.
And I'm inspired because I'm always trying to make my kids laugh and my nephews. And today I did a Zulu dance for my nephew on WhatsApp, you know, video call, and he was thrilled by it. So I would say, you know, and as you can see in WhatsApp, sometimes I'll say something that I'll say, oh, in hindsight, that was a bit silly. But I'm with friends and, you know, we are ourselves. So having a smile or making people laugh, I think, is something that I think is important.
And we appreciate that positive energy, you know, it really, really helps, you know, because at times we are so stressed by this and that. And, you know, it just comes at the right time.
Yeah, so that's the first thing. The second thing is in terms of professionalism, I would say don't be limited because you came from a disadvantaged background, for example, because you grew through a repressive system, it shouldn't hold you back.
Yeah.
Hard work is, so the thing is, I love what I do. I get a big buzz about doing it. And also the ability to then influence others and to make them, it's a ripple effect. You train them to do good and it's a ripple effect. And that's ultimately, I wouldn't say a secret, but that's what has sustained me. That the positivity and the ability to alleviate suffering. But always activism.
Yes.
Always
activism. If we fast forward, Yubes, to a time when you will eventually say, I'm retiring from medicine, what kind of legacy would you want to leave behind? You know, obviously that's still decades from now, but you know, when you eventually get to that point, you know, there will be this person who once inhabited Earth, you know, and he was given opportunities, and now it's time for him to retire from professional life. What legacy do you want to leave at that point?
Okay, I think there'll be 3 legacies. One is if I could find a mechanism that we could find new treatments around, that would be really positive. On a higher level, I would think leaving behind people that I've trained, both in South Africa, Australia, around the world, because it's a global village now, has found something in me that they want to extend themselves with. So leaving an army of people fighting for good would be great.
Yeah.
And finally, I would like to create socioeconomic circumstances, and I'm not sure how to do it, but where there's no homelessness or there's no poverty. I think poverty is the greatest enemy of humanity, and a lot of things come from it. I think homelessness is a very sad indictment on humanity. I think we can reverse all of those things. And I think from a socioeconomic point of view, those are the major issues that I may not be able to solve, but would like to in some small way address.
Beautiful, beautiful, beautiful. So, Yubes, let me not keep you any further. You are almost 30 minutes to midnight where you are. So I just want to thank you so much for giving us 90 minutes of your time. You know, if it had to be broken down in terms of dollars, Australian dollars, I'm not sure if I'll be able to afford the 90 minutes, but you've generously given me that time and the audience, you know, your time. But I've always known you as somebody who's generous, you know, within reason, obviously. And thank you very, very much for just sharing a little bit about who this top professor is, you know, and what drives you, and what are the things you want to accomplish in life. And what I'm hearing is that you are in touch with your life purpose, how to use medical knowledge, how to use your scientific knowledge to actually make the world a better place for others. And that, to me, you know, is what all of us have to try and find. You know, what my gifts, what are my talents, what are the things I'm very good at that I could use to make life easy for others. So I want to say very much, thank you very much.
Fundile, thank you very much for giving me this opportunity. And, you know, when you asked me, there's no way I could say no, because we are brothers from another mother, you know, and
yes.
a long way, and I'm so excited to keep in touch with you.
Thank you very much. And
those who have, I'm not sure who or how many, took the time to listen to us.
Thank you. And also thank you to you know, to Dr. Singh, you know, Vash Singh, for giving us, you know, if she had said no, I'm sure you would not have been able to talk to me. So thank you to her, and thank you to the kids as well. I'll be sending through the YouTube recording so that those who were not able to come in and listen, you can be able to share it with them. So thank you very much. Thank you to all of our, you know, audience through the various channels, Facebook, YouTube, Twitter, Instagram. Thank you for joining us. I hope you were inspired, because the main purpose of this interview was to basically say all of us need to discover something that we are good at. Take the opportunities that are before us. Our circumstances do not, you know, determine how far we can go. And let's be driven by doing good for humanity. So thank you very much for joining in. I hope you have been inspired like I did, and we appreciate your time. Thank you.
Bye.
Bye.